We do a lot with organizing events, as we did for CDA for Pride 2021 this year. And another big thing that I just want to raise awareness of is that we have worked really hard to work on our LGBTQ resources. We have this new postcard which gives you information on how to go online to our online resource guides. You can go to nipridealliance.com/resources, and you can learn about local resources for mental health and counseling, including substance abuse lines or crisis hotlines. You can find local providers with also the healthcare resources. You can take a look and see what are some LGBTQ friendly providers that we have so far identified, also resources, and many of our community partners like NIAC or Panhandle Health District. Also youth, we've done a lot this year on trying to reach out more to younger LGBTQ community members, and there are plenty of social opportunities and also GSA clubs that are so important. Older adults, we also advocate for connection opportunities with older LGBTQ members, and faith communities, community businesses, and more. So please check out our website for those resources. And again, thank you so much, Kootenai Health, for hosting us.
Thank you so much, Jessica. So our first presenter today is Dr. Mark Dalton. He has graciously agreed to give us a presentation today. Dr. Dalton is a hospitalist at Kootenai Health. He's been with us for about 7 years now. Did his medical school at Des Moines University and then residency at San Antonio Military Medical Center. He did spend 4 years practicing in Germany post-training, and we're lucky to have him here. He specializes in ethics, patient education, palliative care, and compassionate care. And he is going to give us a presentation today on creating an LGBTQ-friendly waiting area, clinic space. Thank you, Dr. Dalton.
So I may sniffle, but I've had my shots and I've been sick for 2 weeks, so we should be safe. So yes, I'm Mark Dalton. I'm very proud to be here. Thank you for having me, and I want to thank everyone who's going to be watching the podcast for tuning in, because it shows you're taking an effort and energy to be able to provide the best care possible to your LGBT patients and community and family and friends in the area. I have my notes here, so I apologize. So first of all, who we are, it's, as she was saying, a very diverse group of people, of individuals we're talking about that share a couple of discriminations and biases in common. We share issues with gender identity, sexual orientation, sexual expression, but ultimately in the community it can lead, and in society in the past, as we all know, it can lead to feelings of being an outcast, feelings of discrimination, difficulty getting in the past, especially jobs, housing, opportunities, etc. So naturally, we're always screening the environment to see, who's welcoming, who's not, where should we go, who cares. So that'll be my topic today, is to try to let you know my opinion anyways about ways you can make your waiting reception area and your office more welcoming. So the first step is in creating an inclusive culture. The second we'll talk about is the actual physical plant, so to speak. The inclusive culture, everybody knows every touch point that the patient encounters in your office, whether it's the front office staff, the receptionist, whether it's the CNA, the medical office assistant, whether it's the physician, all those are each opportunities to build trust and a loyal client and to encourage health and wellness, or it's also an opportunity to let them see what they've seen in the past as rejection or discrimination or being put off or set aside. And there are a lot of fears about being misdiagnosed, mistreated, etc. So it is a huge opportunity to educate all of your staff that each and every one of them are very important. Some of the ways you can do this are the educational modules that the National LGBT Center for Health Education puts out, and they try to focus on your sexual behavior rather than your sexual identity. Because as you know, there's MSM, women who have sex with men, etc. So it's important to know the risks based on the behavior, not just identity. Also, you want to educate everyone not to make assumptions based on appearances. If it appears a male or female, maybe not using pronouns without asking their name, etc. Also partner with organizations such as you just heard that can train in diversity education. There's online sites from the American Medical Association. There's the Gay and Lesbian Medical Association. There's the Fenway Institute that, for instance, can give you examples of intake forms. Also, respect the right to privacy. Not everyone wants to disclose everything. You have to meet people where they are with every illness and with every situation. In these situations, we come in and we have an illness, but we have a special situation that we may be afraid to talk to you about that puts it at increased risk for other illnesses that we're afraid to let you know about. So some of the things you can do on your intake forms, excuse me, talk about the preferred names. Transgender people often don't use their given name. They use a middle name, a nickname, etc. And they don't always put them on the legal documents for various reasons. Also, when you talk about male on your forms, you may use male or your gender, you put male, female, blank, transgender, male to female, etc. Or if you don't want to get too specific, just leave blanks. And people, they don't fill them out and don't feel comfortable, don't press the issue. For relationship status, the same thing. Married, single, partner, multiple partners, blank. Orientation, hetero, gay, bi. For teens in particular, they may be very fluid. They're experimenting with their gender identity, their sexual expression, and they may not even know yet exactly. And also be familiar with your local resources. So for your waiting room, some things you can do for your business in general, because we've had a long history of discrimination, we naturally are screening the environment to see, is this a welcoming place or a threatening place? Are these people going to be understanding and helpful or hostile? And we're always just naturally doing that. We always worry, will the other people in the waiting room be condescending or be unaccepting? Will the nurse talk super loud and disclose everything to family members that maybe you don't want them to know? Will we be blamed? Will people moralize, etc.? And so it's a very scary time. Sometimes they make a lot of assumptions about you and your risk because you are gay or lesbian that instantly you are polygamous, for example, but without even knowing. So some things you can also do is post a bill of rights of non-discrimination in your policy or in your invisible areas. On your website, people look for clues. They may see a flag. They may see same-sex couples who are sitting. They have inclusive visitation policies. Put a clearly marked unisex stall so it's not an issue. Put LGBTQ brochures, posters from nonprofit organizations like HIV and AIDS organizations, LGBT, and posters announcing days of observance like Pride Days, National Transgender Remembrance Day, or have a logo of a safe space, that this is a safe space to talk, where you can talk. So we're always screening and looking for that safe space. So in conclusion, we all want to be seen, analyzed, and respected, but it's also a very fearful time when you're in a healthcare environment. You're going to be exposing, some of your deepest secrets, some of your perhaps deepest fears, your deepest concerns about your family or your friends or yourself. And it's a chance to make a positive impact in someone's life for the better or not. And so you can definitely create some very loyal patients and improve their health and lives and those in the community. Thank you very much.
Thank you so much, Dr. Dalton, for that wonderful presentation. I just want to give a reminder, or actually an announcement. We have a really tight schedule today, so we can't take questions during the presentations. But if you have questions, which I'm sure a lot will come up as we go along with these presentations, a lot of new information, I think, for a lot of people, please chat in your questions, and we will have a few minutes at the end to answer everything for you. But again, thank you so much, Dr. Dalton. That was a wonderful presentation. Next up, we have Anna Chase. She's with Family Medicine Residency Program. She's an attending with us. She's been here for about a year and a half. Attended medical school at Wayne State School of Medicine and residency and fellowship at University of Wisconsin. She has special interests in OB, pediatrics, and LGBTQ healthcare. And we're really fortunate to have her here today to talk to us about sexual orientation and gender identity in the electronic health record.
All right. So thank you, and thank you all for joining. Like Emily said, I have the glamorous job of talking about EHR and how do we document all of these wonderful things that we've talked to patients about as we're trying to create a more inclusive and welcoming environment in our clinic and in our hospitals. I did send out a handout which has some sort of infographics kind of touching on that sexual orientation and gender identity, because we could spend hours delving into that, and as they are infographics, they're brief and not all inclusive, and so I also had some resources you can click on to learn more about that if you're interested. Another thing I'm going to briefly touch on is pronouns, because there was a request for how do you ask patient pronouns, and how do you do this in your clinic, and how do you do that, so I'll briefly touch on that. So when I'm seeing patients in clinic, ways that I talk to them about pronouns kind of depends on what I'm seeing them for, what the context is. Most times I just open it up by offering my own pronouns. So I will say, hi, I'm Dr. Chase. My pronouns are she, her. How would you like to be addressed today? And then, go into I see you're here for this and that, and to our normal encounter. If I'm having a new intake, or if I'm doing an annual wellness, which is where I'm updating all those demographics, updating family histories, things like that, I'll be a little bit more explicit in my questioning, but like Mark said, I'm not pushing it if people don't want to offer those things to me. And in that case, I'll ask, what are your pronouns? What pronouns do you use? Here in North Idaho, I tend to give examples like she, her, he, him, they, them, because patients will sometimes give me a blank stare, so I will offer that to them as well. Something I will just say not to do, and I've sort of switched in my practice, because when I first started training, which was not that long ago, the question was, what are your preferred pronouns? And as we know, language is really important and makes a huge difference. And putting the word preferred before asking someone's pronouns really says that it's a choice that they're making and not who they are and not part of their identity. So I would just stress to try not to use that word. And then again, these resources have a lot of like, what word shouldn't I use? Because all of us, you don't intend to say the wrong thing, but sometimes we do. And if you do, just apologize and move on. But those resources have really helped me in how to create a more inclusive language that I'm using and environment. So moving on to the EHR, NextGen is none of our favorite EHR. That's primarily what I use in an outpatient setting. On the handout, because we couldn't use PowerPoint today, I do have a screenshot of what I'm about to talk about, but it's not crazy exciting. So you pull up your demographics, you click on gender details is right underneath that, and they actually have drop downs there for sexual orientation, gender identity, as well as pronouns. And if someone doesn't fit into the options that are there, there is an other where you can free text. Now, my biggest problem with NextGen is that, one of my biggest problems, I'll be clear, is that you don't see any of that unless you go into that exact tab for demographics. None of it pulls through. So a patient's name, if it's different from their legal one, or their gender is different from their legal one on all those records, or their birth sex, then that will be what pulls up, not what they go by, not their gender identity. And so that's challenging. And so I will put alerts on patient charts if it differs. I will always ask the patient before I do that if that is okay, if they feel fine with that being in their medical record. But then it'll at least pull forward that first time that it's coming up, so that they won't have the wrong name, they won't have the wrong identity, or be misgendered, which can be really traumatizing for our patients. And so that's my workaround that I use for NextGen. When we have Epic, the nice thing about that is that similar setup where you can put all of that in, but it will pull all of those things forward. So their name that they use, their pronouns that they use, all of that will be front and center. And you would really have to search hard in the medical record to find those other legal indicators, which are less important in those encounters. So I'm super grateful to be here today. I'm thankful for all of you, just because I'm happy that we're working towards these goals of creating a more inclusive environment. So thank you.
Thank you so much, Dr. Chase. That was a great presentation. And I will say that the alerts, I think, are probably the best way in NextGen to identify if your patient has a name that's different than the one in their chart, because it pops up the first time you open their chart and you can't miss it. I also wanted to mention that Dr. Chase mentioned a few handouts. We will be emailing the handouts to everybody who's attending the forum today. So you will get a copy of everybody's handouts. There's some wonderful information in there. And I think just about everybody has provided some extra information on top of our topics. So next up, I would like to introduce Dr. Robin Beard. She's a doctor of nurse practitioner and a family nurse practitioner. She attended Gonzaga University, completed in 2019. She currently is working at Kootenai in the pulmonary division, and she has completed her doctoral project on improving LGBT health in a community healthcare setting. And she's going to discuss with us today conducting an LGBTQ aware sexual health history. Thank you.
Thank you. Like everybody, I'm so grateful to be invited here to speak today, so thanks so much. I get asked frequently, not as frequently now that I'm in pulmonary, but I worked primary care before, and I would get asked, you know, what kind of questions am I supposed to be asking for a sexual health history? So this is kind of going out to our providers, probably more primary care providers, family medicine type folks. Some of us were, got training on asking sexual health history questions, and some of us didn't at all. And so I'm going to go through some sample questions, and I do have that handout. So if you're interested and these would not be something you would have to ask all of, but just to kind of give you an idea of what sorts of questions that you could be asking when it's relevant to the exam. For many of us, I think healthcare providers, the best we may be doing is asking a patient's sexual orientation. And if that's all you're doing, it might not be adequate. And I can give you a 15-minute conversation about, convincing you why we should be having more of a conversation about sexual health than just sexual orientation. But I got 5 minutes here. It's counting down. So I think we need to be aware, though, that someone's sexual orientation, what information they give us if we ask questions about sexual orientation, that information is going to depend on how safe they feel that environment is that they're sitting in, akin to what Dr. Dalton mentioned earlier. And how much do they trust their healthcare team, right? So that's going to vary from location to location and maybe year to year. We shouldn't assume that how someone identifies their sexual orientation accurately reflects their sexual behavior, and it's actually that sexual behavior piece that we're kind of trying to get information about when we're figuring out what kind of health risks that individual may have. And I've got, of course, more studies than you care to hear about, but one study, for example, Kirker and colleagues showed that 43% of women who have sex with women will identify as heterosexual. That in and of itself is interesting, actually, but they also showed in that study that women whose identity is concordant with their behavior, so women who have sex with women but identify as lesbian, they're more likely to get their preventative exams. So I kind of look at that as saying, more likely to get their Pap tests and their mammograms. I look at that as telling me that they trust their healthcare team to make recommendations on all aspects, including, preventive medicine. So if all we're doing is asking a question about sexual orientation, I think we're missing a big piece of understanding who our patients are, and also missing out, I think, on an opportunity to build a rapport with our patient, which is hugely important with all, but particularly LGBTQ, because so often they have been themselves or seen discrimination occurring around them. So it's almost expected or anticipated. And of course, that's never going to lead to good healthcare, so we always want to try to avoid that. Another study that I found particularly interesting was regarding our adolescent patients. 36 seconds. 36 seconds. That's the average amount of time that's spent talking about sexual health with an adolescent patient in a visit. And, yeah. And despite making up only a quarter of the population, adolescents are making up about 50% of the new sexually transmitted infections in the country. So clearly we're kind of missing the boat in healthcare, having those conversations early on. And it's not a lot better for our adult patients, unfortunately. Even for our adult patients, some of the studies show that even when there's a chief complaint that would be potentially related to sexual health, pelvic pain, abdominal pain, sexual health history questions are only asked about half the time. So on to the questions, what are they? What I typically do is I will ask sexual health history questions after, typically it's when I'm first meeting a patient or kind of an annual exam. I will do the medical history, the surgical history. Important to be asking about any kind of transitional procedures they may have had done in that surgical history if that's not something you normally do. Social history questions, and so this is how I kind of lead into it. As I usually say, next I'm going to ask some sexual health history questions. You don't have to answer any question that makes you feel uncomfortable. That's not the intent. I ask these questions to all my patients because I believe that sexual health is an important part of overall health. And I really have never had anybody refuse questions, and I just head into it. So I follow the 5 Ps that the CDC put out, and it's partners, practices, prevention of STIs, past history of STIs, and then pregnancy. And I got my 1-minute flag, so I'm going to go really, really fast through these questions. Okay, so the partners question is really about determining sexual orientation and risk for sexually transmitted infections. And here's some of the questions you could consider asking. Have you had sex with men, women, or both? How do you identify your sexual orientation? How many people are you sexually active with now? How many people is your partner or partners sexually active with? The practices category, that's to kind of help with risk reduction strategies, and also helps identify what area of, kind of the body you need to be focusing on for that visit if there's chief complaint related. And so some of those questions might be, do you have vaginal, anal, or oral sex? Do you use drugs or alcohol during sex? Have you ever had sex when you didn't want to? Have you ever been paid for sex? The next P is past history of STIs. Obviously, past history could be relevant to current history. So question, what sexually transmitted infections have you had, if any? Did you return for retesting after you had an infection? Then prevention of STIs, that's really for like patient-specific counseling purposes. What type of protection do you use for STIs? Can I answer any questions about, potential sources of protection? And then last is pregnancy. So prevention of, or plans for pregnancy. So that's to help you give either contraceptive or fertility counseling for your patient. So hopefully those are some questions that kind of help spark, your thoughts. And I have a whole bunch that I can send out as anybody is interested. So I strongly encourage sexual health history questions included at least on every exam. Thanks.
Thank you so much. That was an incredible presentation, and I'm sure there will be lots of additional questions in the chat, but that was wonderful. Next up, we have Brooke Allen, who is an advocate for equitable care for LGBTQ patients. She's a public speaker, and I have seen Brooke speak, and extremely compelling. And I am very excited that Brooke is with us today to discuss her experiences and other experiences with receiving healthcare in the area.
Hi, I'm Brooke, and I have the honor of talking to you about the LGBTQIA community experiences when interacting with healthcare professionals. LGBTQIA stands for lesbian, gay, bisexual, queer, questioning, intersex, asexual, aromantic, agender. And for the duration of this speech, I will be using LGBTQ plus community. First, I wanted to share a little bit about myself. I'm 41 years old from Spokane, Washington. I attended Catholic school from kindergarten to 8th grade. And in 1999, I graduated from Lewis and Clark High School. After that, I continued my education at Spokane Falls Community College, where I received my AA. During these years, I started experiencing depression and anxiety, but I didn't know what was happening until I started college. As time went by, my depression and anxiety worsened and eventually became so intense and unbearable that at 22 years old, I tried to kill myself. After a required 2-week vacation at Sacred Heart Psychiatric Ward, I still felt out of place and trapped. So at 23, I decided to move to Seattle. I knew something had to change, and Seattle seemed like the best place to find that change. During my almost 10 years living there, I found my passion for coffee while working at Starbucks. My job there was part of the fresh start I was looking for, but unfortunately, I still struggled with my depression. To cope, I did what a lot of 20-year-olds do. I used alcohol and drugs as my therapist. In 2012, I moved back home to Spokane and continued working at Starbucks until 2017, when I was forced to quit working due to severe hip and back issues. This sent my depression and anxiety into overdrive once more. Alcohol and drugs became my therapist as well as my pain reliever. On March 15, 2020, I entered rehab and have been sober ever since. The reason I'm sharing this information with you is because a lot of my depression and anxiety and substance abuse stemmed from issues with my sexual orientation. I'm a lesbian and part of the LGBTQ plus community. I came out when I was 21, but I knew I was attracted to girls from a very young age. In the words of Lady Gaga, I was born this way. Unfortunately, because of my sexual orientation, I've experienced more than my fair share of implicit and explicit bias from other people, and sadly, quite a few of those people are healthcare professionals. When I think back to my experiences with healthcare providers, there's one instance that sticks out. In 2016, I was experiencing very painful stabbing pains in my abdomen. I decided to go to an ER in Spokane to figure out what was happening. The nurse and doctor did the usual exam, blood pressure, temp, how long have I been feeling like this, what are my symptoms, etc. The doctor decided to do blood work and an x-ray of my abdomen. Then he asked me if my boyfriend or husband had been sick at all. I told him I had a girlfriend and she hadn't had any of the same symptoms. Immediately, his whole attitude changed toward me. He became very cold and rude. He called the nurse back in and told her he wanted my blood work tested for STDs and a full pelvic exam done on me, including an ultrasound. I was so in shock that this was happening that I didn't know what to do. I left there in tears. I felt humiliated and ashamed of myself. I had put my life and trust in this doctor's hands, and he used it to make me feel like I was a sexual deviant and less of a person, all because I'm a lesbian. And unfortunately, this treatment continues today in all avenues of healthcare towards people in the LGBTQ plus community. I spent hours researching statistics to share with you today, and I also spent hours talking to my peers in the LGBTQ plus community. And I came to the realization that while the surveys and the statistics they provide are important, recalling my experiences and hearing about what my peers have experienced made the numbers mean so much more and come to life. One common theme that I heard when talking to my peers was that they feel they're often forced into the role of educator when talking to their doctors. The article, The State of the LGBTQ Community in 2020, a national public opinion study stated, quote unquote, 12% of respondents overall say they have had to teach their doctors or other providers about their community in order to get adequate treatment. The survey included interviews with 1,528 self-identified LGBTQ adults ages 18 or older. People in the LGBTQ plus community are having to spend their limited appointment time explaining their sexual orientation, gender identity, and the terms used to describe both, rather than discussing why they made the appointment in the first place. Why are we as patients having to fall into the role of educator? The answer I found is partially due to healthcare providers not receiving much needed education and training. I had the opportunity to talk to a few people that attended school to become healthcare providers and actively work in the field now. I asked if they were required to take any classes or were given any extra training regarding treating patients in the LGBTQ plus community. A nurse that I talked to said she, quote unquote, received some education surrounding culturally sensitive care, but nothing specifically about working with patients who identify as LGBTQ plus, unfortunately. It's something I sought out for myself so that I could be better in my practice. The organization that I work for has made a big push to educate individuals who are interested, but again, not a required part of our continuing education. I also talked with the psychologist, and she said that unless mental health providers are going to be working specifically with LGBTQ plus patients, there is very little education or training provided and required. An article from July 23rd, 2018, You Don't Want Second Best, stated, the creation of competency modules in physician training programs is a relatively recent development. A survey of US medical schools conducted in 2012 found that only 16% of respondent institutions in comprehensive LGBTQ competency training and 52% had no LGBT competency training at all. Where it is offered, training on LGBT issues may be elective or may only constitute a small portion of a larger course on serving diverse or multicultural populations. Even where there are multiple providers in an area, material and logistical barriers may prevent LGBT people from being able to access them. When providers are not trained on LGBT issues or services are scarce in an area, LGBT people may have few options when a provider discriminates against them or turns them away. This lack of education in healthcare has not only caused the LGBTQ plus community to fall into the role of teacher rather than student, but has resulted in patients facing discrimination from their healthcare providers and others in the field. And we often leave our doctor's office feeling worse than when we first arrived. Sadly, patients that are the target of this kind of discrimination or any discrimination are less likely to seek additional medical care or medical care of any kind. According to the same article from above, quote unquote, those who had previously experienced discrimination were particularly likely to avoid seeking care. In the National Center for Transgender Equity survey, 23% of respondents did not seek care they needed because of concern about mistreatment based on gender identity. This rings true to me personally and to many of my peers that I spoke with as well. It's not only scary, but this mistreatment wears myself and others down mentally. Just because we're part of the LGBTQ plus community doesn't make us any less human than the rest of the patients healthcare professionals treat. Our sexual orientation and or gender identity doesn't change our skeletal makeup on the inside. If I fall and break my arm, who I choose to love romantically or what pronouns I use don't change the fact that my arm is broken. There's a big difference between referring a patient elsewhere because their medical needs are outside a doctor's knowledge base versus outright refusing to treat a patient and treating them with complete disrespect because of who they are. Unfortunately, discrimination deters many LGBT people from seeking care. This definitely hits home for me personally as well. I waited until I was 25 to get my first annual exam because I was scared of how I would be treated by the doctor and staff if they found out I was a lesbian. It may sound ridiculous to some, but one fear that I had was that the doctor would be able to tell I was a lesbian from performing a pelvic exam on me and immediately chastise me for being gay. I eventually found out this wasn't true, but I had also read and heard many stories about people in the LGBTQ plus community being mistreated when seeking medical care. Finally, at 27, my wife at the time convinced me to see her doctor for my first annual exam. But it's scary to think of the illnesses that could have gone untreated during that time and do for so many in the LGBTQ plus community. And what happens when we do finally decide to go to the doctor and we're treated like I was back in 2016? We're forced to look elsewhere for our medical care, sometimes having to drive 30 plus miles to find a doctor that will make us feel like a human being when there's a doctor's office 5 minutes from our house. Some states offer LGBTQ plus healthcare centers or other options such as Planned Parenthood, but unfortunately not all states do. And within the states that do offer these alternatives, not all cities in that state offer the same services. In an article titled "Discrimination Prevents LGBT People from Accessing Healthcare," quote unquote, some people may go to LGBTQ community health centers to avoid such discrimination, but they are not widely available across the United States, and many do not provide comprehensive services. Total of 13 states, mainly those in the central United States, do not have any LGBTQ community health centers. Personally, I now go to Planned Parenthood for my annual exams because they always make me feel safe and welcome. From the minute I walk through the door, I know I am seen as a human and not my sexual orientation. I can talk openly and honestly with the providers there and know they won't judge me. I'm fortunate to have somewhere like Planned Parenthood to go and the transportation to get there, but many other people in the LGBTQ plus community are not as lucky. And I'm gonna kind of skip some of it. I'm sorry, I got the 1 minute warning. As I mentioned before, having to travel so far to get care starts to wear on our mental health. For me personally, each time a doctor, nurse, medical assistant, or medical receptionist treated me differently or abusively because of my sexual orientation, my mental well-being has been negatively affected. Myself and many others already struggle with feeling unsure and different due to our sexual orientation or gender identity. And to have healthcare professionals treat us with such disrespect only validates these feelings. There's some statistics that I have here, and I've provided a list of resources, so you can go back and look at those. It talks about the population of LGBTQ plus and prevalence of mental illness in the community and risk and rate of suicide among LGBTQ plus individuals. And myself and so many of my peers are part of these statistics. I attempted suicide and turned to drugs and alcohol because I felt I had nowhere else to turn when I was coming to terms with my sexual orientation, and because I was treated like I was less than others when seeking help from people that I should be able to trust to care for my physical and mental health. And a lot of my peers shared that, because of this, they seek help in different psychiatric inpatient units, and even their pronouns are not used. Their names that they use are not used. So when you're in a care facility like that for reasons of your sexual orientation or sexual identity, gender identity, why then would you be treated like that? It just perpetuates the problem. I talk further about another experience I had, and I will share my speech so you can continue to read what I have to share. But When I was asked to be a part of this forum today, I was honored. I've been given an opportunity that many people in the LGBTQ plus community will never have in their life. The opportunity to share with you the mistreatment and bias myself and others experience on a daily basis because we're brave enough to be ourselves. My hope is that what I have shared with you today has given you some new insight into how important providing education about the LGBTQ plus community for healthcare professionals is in dispelling these biases, whether they be implicit or explicit. Looking forward, my ask of you is to take the information and stories you've heard here today and make a commitment to further your education about the LGBTQ plus community and put that knowledge to use when treating patients that are part of the community. Also, share what you've heard here today with your peers and speak up when you see or hear patients being mistreated. I had a Starbucks district manager that told me over and over again, there's 2 reasons people don't do things. They don't know how or they don't want to. Being a part of this forum today, you've made the choice to further educate yourselves on the LGBTQ plus community. Now the choice is whether the information you've heard here today will be used to better understand your patients that are part of the LGBTQ plus community, or allow these biases towards and mistreatment of the community to continue within the healthcare field. Thank you.
Thank you so much. That was wonderful, and you're the reason we're here, so thank you for sharing all of that information with us. I appreciate you. Next up, so as a board member of the Pride Alliance, I've had the opportunity to learn a little bit more about the North Idaho AIDS Coalition, and was kind of shocked that I didn't know anything about the North Idaho AIDS Coalition before this. And so I've invited Theresa to come here and share all of the good work that they're doing for our community here, for providing safe and non-judgmental screening and improving availability for screening, safe practices, condom distribution, needle exchange. Everything you do is greatly appreciated, and I wanted to share it with our community here. So without further ado, here's Theresa.
I wanted to take this opportunity to thank you for the invitation. And I'm really grateful and happy to be part of this speaker series. Again, my name is Theresa Davis. I'm the Executive Director of North Idaho AIDS Coalition, otherwise known as NIAC in the community. NIAC has been in our community for 33 years. It formed by a group of 8 gay men during the height of the HIV scare, where the media had perpetuated that this was a gay plague, HIV. The men that were part of that support group, they were ostracized, discriminated against, threatened, and there were very few services available to them. So as a group, they decided to get together, advocate for, and find services to help them with their HIV needs. NIAC has four primary programs under our roof. We have HIV, hepatitis C, and STI prevention program. We have the Ryan White Part B. It's a medical adherence program. We have housing opportunities for people with HIV, which is HOPWA program, and we also have Project Filter, which is a smoking cessation program. I'm going to talk to you a little bit about what the prevention program looks like. I can tell you that NIAC for the last 30-some years has been advocating for the health equity of the LGBT community. We are primarily sponsored by the Idaho Department of Health and Welfare, so all of our services are free. Not only do we serve the LGBTQ plus community, but we also serve those other demographics that we find in our community who are discriminated against. That would be minorities, people who inject drugs, sex workers, that population. Prevention looks like this. Because we're all trained and we all have compassion for, people who may be at risk for HIV. We do HIV and hepatitis C screening free. We have do a little bit of behavioral risk counseling and then linkage to care. Our Red and White Part B program looks like this. This is a huge program that we have. We help people who are living with HIV adhere to their HIV medication, and we do that by linking them to specialists in the community, as well as providing transportation so that they can get to their doctor's appointment. We also help them with ADAP program, and that is a drug assistance program, helps them to pay for their HIV medications. We have transportation, we help them with housing. We also have a food bank for people living with HIV it's a very low barrier food bank, meaning that if a person needs food, they can come in and get as much of it as they want they don't have to have a lot of paperwork, a lot of documentation. That is not necessary. That has been funded by the Pride Foundation and the Idaho Department of Health and Welfare. I'm going to switch over to our Hopper program, and that's a program where we help people stay in stable housing, people living with HIV. We know for sure that people are not going to adhere to their medication if they do not have stable housing, meaning if you don't have a roof over your head, chances are you are not going to take your medication. And we know this. If you take your medication on a daily basis, it lowers the virus to the point where it's undetectable, well, not undetectable, but untransmittable. That is the campaign that we advocate for all the time. It is U equals U. Undetectable means untransmittable. So that's one of the programs, that's one of the campaigns that we're constantly advocating for. And so we try to help people to stay in stable housing, although that's a little bit challenging in our area, especially with the housing boom that we've experienced. But we do that. Meaning that we will pay for their rent, and also if they get a termination notice for their utilities, we will help with that. We will also help with their mortgage, transportation. We'll take people to the store, we'll take them to the doctor's appointment, we'll take them to where they need to go in the community. Then we have our fourth program, which is called Project Filter, and that's a recent addition to NIAC, and that's where for those that are interested, we can help them with smoking cessation. We just now got nicotine replacement therapy, and so we can help people with lozenges, patches, and gum if they come in. And it's just low barrier. We're trying to keep everything very low barrier. So that's another program that we have. We also have a harm reduction program, meaning that we're addressing the opioid epidemic right now. We're doing our best to address that and trying to mitigate the transmission of HIV through harm reduction. We also have a mobile testing unit that we can take into Region 1. And we are in Region 1. We're partnered with Panhandle, and we take our mobile testing unit to all of their clinics. And I will give you a flyer, a schedule of when NIAC will be at Panhandle's clinics. And we also have a satellite program in Moscow with Laytal Recovery Center. That's pretty neat, where we go down there and we give them supplies, and we also do their HIV and hepatitis C testing. Let's see, what else do we have? The one thing that I do want to say is that I think that NIAC has been, for 30 years, we have given it our best to be very inclusive in the work that we do. We understand about pronouns and we use them. Our questions that we have on our intake form are low barrier. We don't ask a lot of questions because we don't really feel the need to ask a lot of questions. If you want to share that information with us about your sexual orientation, you're more than welcome to, but it's not necessary. We understand the discrimination and the lack of equity that people in the LGBT community have faced in terms of sexual health care, and we are here to make you feel welcome, to help you get the assistance that you need, and really to be a support for you. That's our purpose, that's our mission, that's why NIAC exists, is to get those services out into the community, to embrace populations of people who have never been embraced before, who, matter of fact, are ostracized and excluded, and to combat the HIV epidemic as well as the opioid epidemic.
Thank you so much, Theresa. It's truly phenomenal work that you're doing, and we appreciate you so much. So thank you. So we have a couple of questions, and may not be answers to all of our questions today, but at least we have started the conversation. One of our questions, I was hoping Dr. Chase could help us with answering. That'd be great. Yeah.
So this question says, how are the clinics handling sensitive info such as gender identity and sexual orientation for teenagers who have not disclosed to their families now that patient notes are completely available and the idea of teen confidential notes is gone? And so there are a few ways around this, and I feel like this just goes back to any sexual health question I'm asking a patient, because a lot of times they don't even want their parents to know that they're sexually active, let alone with whom. And so what I will do is I put it in places that aren't in the notes. So on the problem list, you can add notes, and that will not be disclosed when parents are looking at that. So I will put something like health history as the problem on the problem list for like well child exam. And then under that, add a note and put the date on it that I talked to them about it. So like I know personally, and then write a little bit more information. And same thing, there's sticky notes in NextGen you can use as well. So basically I just get around it in that way that I hide little pearls in other places about the information I've collected. I also have that conversation with my teenage patients always about like, do you want me to put this here? Did you talk to your parents about this? I always encourage them to, because obviously we want them to feel like they're supported by their family, but it's not always safe, and that's not always the case. When my colleagues laugh at me because it's always like when we get epic is my line, but there is a way that you can check like this note has to be confidential, and a lot of times for teens it can have to do with safety and things like that, so that option is there, and I don't know that we have that in NextGen. So thank you.
And you may be able to help with one of these other questions too, Dr. Chase. Is our new EPIC admit questions going to prompt questions of this nature, so like sexual history questions? Do you know if the admit form, like the question?
Oh, yes, like when they're like a new
patient, yeah.
Yes.
Okay.
So my thought is when we do that, I was gonna just totally have us rework the intake form for people because it's a mess and I don't enjoy it, but I'm just repeating.
So Dr. Chase is going to take care of that for us. So, good work, thank you. And the next question is, how is Kootenai going to change and educate staff on this topic? And I think this is a start. I think this is, as Brooke said, we have presented a lot of information here. The fact that so many people joined is just, it makes me so happy and proud that we're having this. I think at the last count was 111 people on the WebEx. So I'm just absolutely thrilled that so many people are excited about this topic, available and willing to watch. And then I know that there's people who are going to watch this on a recording. And so this shows that people want to learn more, that we are willing to learn more, and we're going to take this information from here and use it to inform our practices in the future. That's the hope. So hopefully there will be more events like this in the future. This is a lecture series, inclusive care lecture series. Not all of the lectures will be on LGBTQ+, although we probably will have another one in the future. Our next inclusive care lecture is going to be on the topic of the Coeur d'Alene tribe. So we'll be learning more about the tribe, about their culture and their potentially their barriers to receiving healthcare with us at Kootenai. And so I'm very excited for that one. So hopefully we'll take this information and run with it. So thank you so much to everybody who's joined in with us today, and to everybody who presented. I just appreciate all of you so much. So thank you.